Hi, my name is Rafael Bejar. I'm from University of California at San Diego, and I've been asked to speak to you today about how molecular profiling should be used to guide therapy for patients with MDS. Now, this is a really broad topic that has a bunch of different layers, some of which I covered in my talk at the Acute Leukemia Forum. What I'll do today is hit some of the highlights of that talk, sharing instances where we can use molecular information to better care for our patients with MDS. So I'll start with what I consider the obvious, which is that MDS is a disease caused by somatic mutations in blood cells. So these mutations aren't just markers of the disease, they truly are the cause of the disorder. And the wide variety of mutations that patients can have can tell us something about the flavor of MDS that they happen to have. So I perform DNA sequencing from all patients at diagnosis, and often again at several points during the course of the disease if I suspect there is progression. And what we can do with that information is help us understand what kind of MDS people have, what their prognosis is likely to be, and in some cases, even what therapies are best suited for them. I'll give you some examples. If a patient at diagnosis has been found to have intermediate risk MDS, for example, they might be treated either as a higher risk patient with more aggressive treatment, or perhaps as a lower risk patient with more supportive care. Mutations can help us understand the likelihood that this patient will go on to develop acute leukemia or perhaps progress to more aggressive disease. So sequencing at the time of diagnosis is important from that standpoint. Certain mutations, like mutations in a gene called TP53, and mutations in genes that are more associated with acute myeloid leukemia, like mutations in the IDH genes, RUNX1, NRAS, and several others, are considered highly adverse. Whereas other mutations, like mutations in SF3B1, may actually suggest a more indolent course if there aren't other negative features associated with it. So mutations can be helpful in that regard. They help us refine prognosis. In the future, we'll have more dedicated expert guidelines that help us understand how to compare mutations to other clinical features that we use for prognosis, such as abnormal chromosomes, the number of blasts in the bone marrow, and the degree of cytopenias that patients experience. The other place that mutations can be helpful is they can help us classify patients. Sometimes patients might be on the edge of having a myelodysplastic myeloproliferative disorder, like CMML, for example. There are certain mutational profiles that are more indicative of CMML, in particular mutations of TET2, ASXL1, and SRSF2. And when these occur together, are very highly specific for this disorder. So that helps us put patients in the right classification if the clinical picture isn't entirely clear. And finally, what I focused on in my talk at the Acute Leukemia Forum was that certain mutations can help us identify therapies for patients. Now, MDS, unlike AML, doesn't have as many direct targeted drugs that actually impact the mutations that we see in our patients. But that said, they can still be useful. The most useful targeted therapy you may already be familiar with is a drug called lenalidomide. And lenalidomide is particularly effective in patients who have an isolated deletion of chromosome 5q. These patients are very highly sensitive to the drug. They have a greater than 70 to 80% response rate, and these responses are deep and long-lived. So we often will reach for lenalidomide for patients with del5q who need treatment, even though they don't necessarily have higher risk features. Now, there are other mutations that can predict resistance to lenalidomide, like again, mutations in TP53 and RUNX1 being two of the most common. And these can help us gauge our expectations, but shouldn't necessarily be used to exclude patients from treatment with this drug that can be highly effective in this patient population. The other drugs that we have that are potentially specific for the mutations that patients carry are drugs that target IDH, the isocitrate dehydrogenase genes 1 and 2. There are drugs, ivosidenib and enasidenib, that target those mutated genes specifically. And while these mutations are not common in MDS, occurring only in 3 to 5%, they might be effective in those individuals that happen to carry such a mutation. And lastly, I'll mention another drug called Loospadercept. Loospadercept is an injectable agent that stimulates the production of growth cells in patients with lower risk MDS. It has been studied particularly in patients who have ring sideroblasts. And as you may know, patients with ring sideroblasts have a high frequency of mutation in SF3B1. Now, we don't believe that Loospadercept is directly targeting SF3B1, but we know that it is a marker of patients that are more likely to be sensitive to this drug. So at the moment, the FDA approval is in these patients with ring sideroblasts, and further studies are being done to determine if other patients might see a similar degree of benefit. Lastly, I want to talk about a gene called TP53 that I mentioned a couple times before. This is a gene that is considered highly adverse, and patients who have this mutation typically have other high-risk features as well. They have complex chromosomes, they have high numbers of blasts, they may have profound cytopenias, particularly thrombocytopenia, And unfortunately, these patients have a very poor overall survival, even after aggressive treatment like bone marrow transplant, largely because their disease is resistant to treatment or will relapse quickly. Novel therapies are being developed to target patients who have these TP53 mutations, representing about 10 to 12% of patients with MDS. And hopefully in the future, we'll have more to offer this group of patients as well. So just to summarize, it's important to check mutations in patients with MDS because it can tell us a lot about what kind of MDS they have, what their prognosis is likely to be, and more now, what kind of therapy might be best suited for them. Thank you.